I am presenting a case of how to seal the uterine artery at the origin in certain cases where the uterus is very big and you want to seal the uterine artery for various reasons at the origin. Here I am just showing the ureter, how close the ureter is to the uterine artery near the isthmus. Just to understand the anatomy, I am just showing the ureter and its relation to the isthmus of the uterus, where we routinely coagulate the uterine artery. So that's the ureter. We can see that just opening the peritoneum, we were able to identify the ureter. In some cases, like a huge fibroid we want to treat, or if it is a endometriosis where it is difficult to reach the uterine artery near to the uterus, in those cases, entering the retroperitoneal space and identifying the uterine vessels close to the origin is much more easier than reaching the uterine artery near the isthmus due to the change in the anatomy. So once we had a fair idea where is the ureter, now we'll try to expose the retroperitoneal dissection. Usually retroperitoneal dissection is started by opening the peritoneum between the round ligament and infundibulopelvic ligament. So open the infundibulopelvic ligament as much as possible so that we can see the ureter entering into the pelvis at the level of sacroiliac joint, which is over the common iliac artery dividing into internal iliac artery and external iliac artery. After opening the peritoneum, usually we see external iliac vessels. In this case, we are seeing the external iliac vein. Care should be taken that dissection is done slowly and fiber by fiber dissection. Try to avoid the bleeding in this area, which may stain the area, and once again it may disturb the anatomy. So external iliac artery, and that is the ureter that is seen there. These loose cellular tissue contains small vessels which better divided using the energy source than teasing them, which may lead to small bleeding which can stain this area, and we find it difficult to identify the retroperitoneal structures clearly. So ureter is seen in the medial fold of the peritoneum. Right side we are able to see the we can see just teasing was sufficient to start the bleeding. So this bleeding will stain the area. So better to have a complete hemostasis, especially when you want to do a retroperitoneal dissection. Sometimes it is not possible to have a complete bloodless field. but still you are able to identify the anatomical structures. So this is the pararectal space. Lateral pararectal space is being opened. Lateral to the ureter is the lateral pararectal space, and medial to the ureter is the medial pararectal space. So that is the uterine artery that is being dissected out, which is identified by a tortuosity in its course and goes medially and crosses the uterine artery, crosses the ureter, and it is the first medial branch. These are the three ways to identify the uterine artery. One is that it is the first medial branch of the internal iliac artery. Second is that it is a tortuous vessel. When compared to other vessels, you can see that it is more tortuous, and it is the vessel that crosses the ureter from lateral to medial side. So little further dissection is helpful in identifying the internal iliac artery and their anterior divisions. So now we are having a better idea of what structures we are dealing with. So we can see that is the internal iliac artery giving a anterior divisions. So that is the uterine artery. So this is the main trunk of the internal iliac artery, and that is the obliterated umbilical artery that is going anteriorly, and that vessel that is crossing from lateral to medial. So we are showing all the three components of the identification of the uterine artery. It is tortuous, it is the first medial branch, and it is the vessel that crosses the ureter from lateral to medial. So that is the ureter. So that is being crossed by the uterine artery from lateral to medial. So we are having a further dissection just to have a clear-cut idea. So that is the uterine artery. So we can see, though it is tortuous, it is much easier to coagulate at this site, especially when you are dealing with a large fibroid uterus, or if you are dealing with the inflammatory conditions or endometriosis. In those cases, reaching the uterine artery near to the stomach is not easy, or it may be associated with the more blood, and down that is running straight is the superior vesical artery. So these are three vessels that are identified. One is the uterine artery, superior vesical artery, and obliterated umbilical artery are the three vessels and the main trunk of the anterior division of internal iliac artery at its before it is dividing into the major branches are seen in this. So this is the main trunk of internal iliac artery. posterior divisions go directly posteriorly. They are not seen in this dissection. So that is the uterine artery that can be very easily coagulated. So before coagulating the uterine artery, make sure that we are well away from the ureter so that lateral spread does not damage the ureter, or you can save the ureter by using a atraumatic rasper and then you can coagulate. So you can further confirm the obliterated umbilical artery by pulling it. So once you pull it, there will be movement in the medial umbilical ligament. So that is a confirmation that this is an obliterated umbilical artery. So now routinely you can coagulate the uterine vessels near the isthmus. But in some situation where it is necessary, it can be very well coagulated at its origin. Thanks for watching this video.